Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research. And we're here to explore a wide range of topics with you through interviews with content experts.
Hello, this is Kevin MacPherson, and today we're continuing our interviews of the various presenters from the 2021 hybrid AAOMPT conference. And we have the privilege of speaking to Carleen Jogodka as well as Bryan Kist regarding their presentation, which was care delivery at the right place and time. Can PTs meet more recovery needs of hospitalized patients? Now, before we dive into some of the questions regarding their presentations, let's go ahead and ask each of them to just give us a little bit of background about themselves, including where they underwent their fellowship training. So Carleen, would you like to go first?
Sure, no problem. And thank you, Kevin, for having us on your show. This is great to be here and be able to explain what we're doing. So I came to PT as a non-traditional student. 10 years of doing laboratory biomedical research and decided to take a different direction and work with humans instead of mice. I graduated from Regis University in Denver in 2004, moved to Arizona for a full-time position in the ED right after graduation. I've worked with the same organization ever since, and the career focus has been on developing and refining skills to meet the needs of emergency patients. So with that involved fellowship with Evidence in Motion. I finished that program in 2012 and really working to educate anyone who is interested in learning more about emergency PT continues to be the focus of what I do. So that includes working on our third annual emergency PT conference, which is happening in just a few weeks to refine our skills even further.
And Bryan, how about you?
Thanks, Kevin. I appreciate you having us. I began my career after graduating from New York Medical College in 2001, and my path was a little bit different than Carleen's in that I jumped around from different locations. So I started in acute care and worked my first few years bouncing around different rotations, and then pursued outpatient physical therapy. I then went on to get my transitional doctorate from Regis University and then got my OCS. And following that, I transitioned back to a hospital-based outpatient setting in 2012 and decided I needed a little bit more to my clinical practice and enrolled in, at the time it was EIM, but while I was in the program, they merged with Bellin College. So I currently work at ChristianaCare in Delaware, which is a level 1 trauma center. And it makes for some very interesting cases in the emergency department.
So thank you both for joining us today. And I want to just say that this area of practice for physical therapists is very exciting to me. I'm an assistant director of clinical education. I'm really hoping to get some students more exposed to this area. But for me, when I look at this prior to your presentation, a lot of what I focused on was just early access. However, at the beginning of your presentation, there was kind of a process where you delineated kind of the skill set required for, say, acute care versus outpatient, and how there might be a gap in skill sets or something missing. Bryan, do you mind telling us your thoughts on that, since you spent a fair amount of time there? And then Carleen, if you want to add afterwards.
Thanks, Kevin. I think what we were going for was more a matter of some of the qualities and the characteristics that would make a good emergency physical therapist. And it was much more a blend of the medical knowledge that the care therapist has, as well as some of the autonomy and the outpatient clinical decision-making skills that the outpatient physical therapist has. So it's kind of a unique area where these two worlds kind of kind of merge, and there are certain characteristics from each area of practice that are valuable to the emergency department.
Carleen, did you want to add to that?
Yeah, in terms of differences between acute and outpatient, really when people are in the hospital, the focus is on a problem that may not be a traditional PT problem like you'd see in outpatient. So really that ends up turning towards disposition training and understanding medical knowledge, but not necessarily focusing on other aspects of PT training in doing procedure things. So if somebody comes in with knee pain, I'm going to help them with, advancing whatever problem they're having associated with that. Whereas in the other setting, in acute care, they may have knee pain, and that always seems to take a back seat, or whatever PT problem that we could be addressing, because it's all about getting them out quick rather than addressing what may speed up getting them out quick.
That's fascinating, and whether I knew the link or not, I know that I would frequently tell my students, I tend to use it more from an aspect of there are benefits to the orthopedic coursework that you're taking right now that you can use in acute care, even though I know you really don't want to be in outpatient, you want to be in acute, but you can see how quickly you can make somebody's, in this case, knee feel better with some joint mobilizations before you go for a walk, which may get you the 300 feet or whatnot. So thank you for giving me a better reason for telling them they should learn these skill sets, Carleen.
Yeah, and actually, in thinking about this a bit further, since COVID, what I've done is the pain education that we've received and seeing how riled up people can be and how much anxiety is playing a role in their breathing. I feel like I've used a lot of pain concepts in helping calm individuals down to help with their breathing, and that too makes a huge difference. So it's just blending of those skills.
So there's a lot to unpack there, but we're going to stick with the conference presentation just for our audience and in the format of our podcast. So Carleen, the next question goes to you. You made it very clear that you felt we should not call these PTs that work in emergency departments emergency department PTs. Why not?
Well, again, this has been sort of a thought and process for many years that ended up going to discussion at our first inaugural conference in 2019. That really, one, Kevin, you can call yourself whatever you choose, of course, but really looking at how hospitals have changed nomenclature over, is it ER, is it ED, and currently our facility for the last 5, maybe 8 years has been emergency center. So if we have a title that is tied to a specific location, it could end up in us dating ourselves and steering ourselves away from that location. It also gives consistency to how other professionals are calling themselves, and it's not an ED doc, it's actually an emergency physician who practices emergency medicine. Same goes with nursing, same goes with PAs, even their society names. So SEMPA is the Society of Emergency Medicine PAs. There's not department tied into any of that. So doing that name change early, of course, is going to save a lot of cost down the line versus if we do it now.
Good. That's very clarifying. I mean, I would not call myself an outpatient department PT, so that makes complete sense to me. Speaking of outpatient, Bryan, you tend to go back and forth between the ED and a standard outpatient setting. What changes as far as your work hat is concerned?
That's a great question, Kevin. And if you asked me this earlier in my career, I think I would have taken off certain hats and it changed how I was practicing in different settings. But I will be honest with you, since fellowship training, there's really not much difference in how I go about my process of figuring out how to treat these patients. And if you think about the emergency department, it's like having a patient come to you via a direct access. There's still a lot of questions. There's still a lot of unknown with the patient as far as what the patient's problem is. So it's those active listening skills that are important and really figuring out what is it that this patient needs in this moment in time. So it does not change much from the acute care setting to the emergency setting, with the difference that I have a lot more flexibility within my schedule. I'm not set to that specific time frame for the outpatient visit. So if someone needs a little bit more time, I can give them more time in the emergency.
As fellowship trained individuals, and I'm very familiar with both of your fellowships, having gone through Regis and also having instructed for Evidence in Motion, really there's two concepts that come to mind. One is the evaluation is not only done on day one, because we have two, that test retest within the session, test retest across sessions using outcomes measures or otherwise. So when I think about a PT who's practicing in an emergency setting, I think of, well, what's the handoff process look like? What does day two look like? Are you going to be involved in that? So Carleen, I'll shoot this one to you first, just because we kind of have some insight on Bryan's right now, but what does that look like for you?
That really focusing on that single episode when it comes to an emergency patient, that you don't get that second chance. I'm doing test retest within the same session and trying to establish, is this the problem that the patient has? And is this something that they could continue doing at home? Or if they do need further investigation, handing that off to an outpatient PT who is experienced in that area of practice. So if it's somebody who's spine versus somebody who has more TMD problems, I know in the community, without giving any kind of financial or stark issue with handing them off to a specific practitioner, I give them choices who they can follow up with. But I'd say, yeah, it's focusing on that single episode. One more thing I can add to that, if it's a person who's admitted, I may see them up on the floor, or I may give a handoff conversation to another therapist who is seeing them on the floor for just hints and ideas, what I didn't get a chance to look at or what they may want to look at, just to make that process smoother.
Bryan, how about your processes for day two? And because Carleen put in a really good kind of dynamic that I didn't intend with the question, and I love it when the interviewees come up with much better ways of taking the conversation than I do. What does that handoff process look like for acute? They're going upstairs, or to outpatient? They're coming to a clinic like yours.
So I'm part of that acute. When I'm in the emergency department, I'm part of that acute team. So we have a system in place where I can give someone some information on the patient, especially if I feel like it's pertinent to their care. But the thing that's most important here, and I agree with Carleen, she hit on this quite well, is we might not get a second chance, especially within the emergency department. There is a push to get the patients out pretty quickly, especially in a busy emergency room setting. For someone that doesn't need to be admitted, we don't want to be admitting them. So it is important to educate the patient and really empower the patient. I feel 100% that is the thing that's most important for that transition, because we probably will not follow up with them. I am much more likely to do evaluations than I am follow-up treatments in the acute care and the emergency role. So it is a matter of empowering them and making sure that they know what it is that they need to do or where they need to go for follow-up.
Just extremely insightful, Bryan. And it dives me into the next question, which I think is probably what several people think of when they think of PTs in the emergency setting, especially if they've been in management or they've been subject to productivity standards. And that is, you both have talked a lot about really spending time educating the patient, really making sure that you get down to the root as best you can and get them off to the right direction. The number one thing that physical therapists do, in my mind, that we do not get paid for is educating patients. So what does that look like from a reimbursement standpoint? Like, I'm confused. It's two different areas.
So my understanding of this is that, and this is how I've been educated to do this by my seniors, is if the patient is not admitted, it's still outpatient therapy. So we are still following the exact same rules. Education falls under your initial evaluation. So if you spend the time, it's just an increased amount of time within that billing. So there's really not much difference that occurs as far as the billing from an care or from an emergency setting as it would be from an outpatient setting.
Excellent. Is that your similar experience, Carleen?
Yes, and in emergency care, they are considered outpatient by billing standards. So it's Medicare Part B. So we are definitely subject to that 8-minute rule. And like Bryan said, education is a part of their evaluation, or in some cases, education could be a part of them transitioning home and doing self-care. So that also is an area that could be captured.
Simple answer to what I thought was going to be a much more complex question. So thank you both for the insight there. Now, I'm sure there are going to be listeners that are very, very interested in either creating some sort of emergency setting access for their company, or they're already in the acute care setting and they want to see if there's interest in their administrative team taking the direction of putting PTs in the emergency setting. Are there any kind of recommendations that you would give? Carleen, do you want to take the first stab at this one?
Sure. First of all, like we mentioned in our conference session, the toolkit by the APTA for emergency PT practice is available, and the version 2.0, if it's not already out, is coming out very soon. So that is one place that many people have started. And in terms of your specific facility too, is expanding conversation about early mobility that may already be existing in your hospital, in the ICU, et cetera. Hitting some of those important benefits and capturing the audience that way is a way of bringing them into ED. So now we're doing early mobility.
My experience in the emergency department is different than Carleen's. Carleen has been in the ED for a long time, and she has been advocating for emergency physical therapy far longer than I have. I kind of came into the emergency department as a way of dealing with the pandemic. When I was initially full-time employed as an outpatient hospital-based therapist. And when the outpatient clinics were closed during COVID, I needed a place to be stationed. I needed a place to work. And my senior was the one that really was the brainchild behind putting me in the emergency department. And he kind of paved the road for me to be in there. So I've had the support of my organization in the emergency department from the get-go. And it's been a great experience as far as like establishing relationships. If someone is interested in pursuing this actively, I took a little bit more of a passive role, and it worked out for me. But if someone's looking to take a more active role, I agree with Carleen. It's a matter of really trying to advocate for that early access to care, and really trying to push forward how physical therapy can assist in getting the patients out the door faster and safer.
So today's discussion has been very insightful. So Carleen, there is definitely a push to create a new academy for emergency care PTs. If you had a chance to give the listeners some background on why they should be in favor of this, what would you say?
I would say that's a fantastic idea, Kevin. That actually excites me a lot, because just a few years ago at one of the Graham sessions, I was invited to speak on this very topic as part of a Shark Tank argument why we should be our own academy. We have a lot of very unique aspects working in emergency care that cover really all of the different sections of the APTA, whether it be women's health, whether it's seeing critical care patients, orthopedic, et cetera, et cetera. So it's really hard to house us in any specific academy itself. So that is good news to hear.
Well, being a unique setting and being something that every time I learn something more, it makes more sense to me how different those PTs practice compared to every other setting. I can't officially say I'm in agreement with where we need to go with it as a delegate, but I think you guys are making a really good argument. So now, this has been a great discussion, and we very much thank you for your presentation at the conference. Bryan, do you mind giving us some potential contact information if we have any listeners who might want to follow up with their own questions?
Sure. So I work for ChristianaCare, and our website is www.ChristianaCare.org, or you can contact me directly at Kist, K-I-S-T, @ChristianaCare.org. That's my email address and the easiest way to get in touch with me if you have any questions.
And Carleen, do you mind doing the same?
Nope, not at all. I'm reachable, of course, through social media on Twitter and on Facebook. I happen to be the administrator for the Emergency PT private group. You just have to submit a couple simple questions, but I'm certainly open to being contacted.
Well, Dr. Jogodka and Dr. Kist, thank you very, very much for your time today, and I hope you have a wonderful rest of your week. Thank you.
Thank you, Kevin.
Thank you very much, guys.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at AAOMPT.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AAOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AAOMPT. The information presented should not be used as personal health care or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.AAOMPT.org, which you can find in the show notes.